Hi, welcome to the Magnus Mazzoni Center. This course is on co-occurring disorders. I am your host and professor, Nora Magnus Mazzoni. I'm a licensed professional counselor, a licensed alcohol and drug counselor, and a master herbalist. On our agenda, we're going to talk about purpose, the purpose of why we're here, and the topics that we're going to talk about. What is addiction and the stigma, and neurobiology of substance use disorders may have to wait till the next time that we meet, because it's a heavily infused topic of many neurobiology, receptors, and how the brain functions. So that's probably going to be the next time that we meet, so I can spend more time on that with you. The purpose of why we're here is to really discuss what are co-occurring disorders, what is substance use disorders, addiction, and how does that relate to mental health? So let's get into talking about it. What is addiction? What is a substance use disorder? You'll hear addiction, substance use disorder, they go hand in hand in a lot of ways, but you can also hear recovery. So we're going to talk a little bit about the verbiage that we use and really how that benefits an individual, a client and an individual. There's two definitions that I highly recommend looking at and exploring when it comes to the definition of substance use disorders and addiction. The National Institute of Drug Abuse, NIDA, classifies addiction as a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences, so negative consequences. It is considered a brain disorder, right? So we'll get more into why it's considered a brain disorder, because it involves functional changes to the brain circuits involved in the reward pathways, stress, and self-control. So again, we're looking at it as affecting the brain. It's a mental health disorder, technically, by this definition. The National Institute of Mental Health classifies substance use disorder as a mental disorder that affects a person's brain and behavior, leading to a person's inability to control their use of substance use, such as legal or illegal chemical substances, drugs, alcohol, or medications. Again, it's considered a mental health disorder. I really stress this. A lot of people, professionals, institutions, insurance, do not view substance use disorders as the same as a mental health disorder. Still to this day, if I was going to bill for a substance use disorder, it is very different than billing for a mental health disorder. It is easier to bill for a mental health disorder with the documentation that I would provide for insurance reimbursement than it is to have the ASAM, 6 ASAM criteria, and the assessments that are needed for a biopsychosocial in order to seek support and advocacy for an individual's stay in a treatment center, whether it's inpatient, detox, day treatment, outpatient, intensive outpatient, those types of different levels of care. It is heavily influenced by insurance, and it is reimbursed due to documentation. And the documentation is very different in assessing and supporting a person when it comes to financial assistance from insurance. When it comes to mental health, yes, it can be limited in how many sessions an individual gets per year or that they're allotted per year. However, it's easier to seek reimbursement with an individual's insurance for the documentation purposes. This part is part of the stigma. We're going to talk about the stigma. There is a heavy stigma in the nation, in the world, with many different cultures when it comes to substance use disorders. The stigma is that people believe that people can control their substance use, when in fact, it is a brain disorder. And there's a difference in that. And maybe we'll have to have another podcast, a class on that topic. but for now, right, it is classified through the definitions as a mental health disorder. My qualifications for teaching you about co-occurring disorders is that I myself have a history of an unbalanced family system. I was raised in an unbalanced family system. You might know it as dysfunctional family system. Um, However, I believe that family systems can be rebalanced. And so I tend to use the term unbalanced. I had 11 years of recovery from substance use. I love my life in recovery. I support other people who have struggles with substance use. And I want to help and promote normalizing that substance use as a mental health disorder, very passionate about that, and to be able to treat it as one and the same for professionals to be able to view it and be able to know how they can support people with substance use disorders as well as their mental health disorder for co-occurring treatment and therapy. My career, I started my career as an LADC at Hazelton Betty Ford Foundation. I worked there for roughly 4 years. I've gained significant amount of experience as a flow counselor, working in detox center, working in inpatient, residential, outpatient, day treatment, all levels of care, and intensive outpatient. And then when they switched to the model of outpatient. I loved working with the people that I worked with. I would never change the experience that I had at Hazelton Betty Ford. I also have been providing, after that, co-occurring therapy for another additional 4.5 years. And I am very passionate on making sure that people can have services. When it comes to seeking mental health and substance use and not having to see an individual who is a licensed alcohol and drug counselor and then have to also see a mental health provider, but doing it with each other as a co-occurring therapy. I've developed co-occurring therapy curriculum, treatment programming, and right now I run the Magnus Mazzoni Center that offers biopsychosocials and concierge outpatient services for mental health and substance use disorders. I'm also an adjunct professor and has been an adjunct professor at the University of Nebraska, Omaha. And I still am very passionate about educating people when it comes to co-occurring disorders and multiculturalism. Part of Nebraska, they have a pain and substance use disorder called ECHO that they meet once a month to support people who have co-occurring disorders. So I'd encourage you to check that out. There is a real stigma of substance use disorders. As you have heard and probably have experienced, there is a lot of people that believe that it is a choice and really view it as a negative experience, especially if there's relapsing that occurs, that people get frustrated, angry, they view it differently, that the person has a choice and that they're choosing not to stop. Though there's a lot of information when it comes to the real stigma of substance use disorders. In a study by the Recovery Research Institute, the participants were asked how they felt about two people. So we're going to look at this case study, and it's all about the words that we use, how we identify people, how we speak about people, and then the perceptions that we have about people based on how we address them or speak of them. So one person was referred to, so we're going to be looking at two people in the same case study, and the differences is how we speak about these individuals. That shows the real stigma of substance use disorders. One person was referred to as a substance abuser. The other individual that was looked at was the other person was having a substance use disorder. Okay, so substance abuser, having a substance use disorder. Basically, they have the same concerns, though one is saying abuser and one saying substance use disorder. Know No other information was given about these hypothetical individuals. Okay, the study discovered that participants, the people who were participating in the study, felt the substance abuser was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening. So feeling threatened by them, more likely to be blamed for their substance-related difficulties, so blaming, and less likely that their problem was the result of an innate dysfunction over which they had no control over. They were more able to control their substance use without help. That's what it was viewed at. So when we look at who participated and what was the study consisting of, the survey was of 314 individuals. There was 35 questions of perceptions and feelings involved when the participants were asked. 20% were students. 29% of these people that participated in this study worked outside the healthcare or were unemployed or retired. 5% did not report any occupation whatsoever. 31 years old on average. There is 81% were white, 76 were female, half had a bachelor's degree. So half of the people were pretty educated. They were asked these questions. Who would benefit more from treatment? Likely to benefit from punishment? Likely to be socially threatening? Blamed for their substance use difficulties? Their problem was a result of an innate dysfunction over which they had no control over, more able to control their substance use without help. Now let's look at this scale. The scale comparison for the substance use abuser and substance use disorder descriptive labels. So this yellow color is for the substance abuser, okay? So abuser. The blue or teal is the substance use disorder. The means of substance score is right here. So the percentages, as you can see on top. So when it comes to the treatment question, who would benefit more from treatment? 69% believe that a substance use disorder individual would benefit more from treatment. 41% believed that it would be the substance abuser. When it comes to the punishment question, as you see, likely to benefit from punishment, they believed significantly, percentage-wise, 67% of participants in the study believed that the substance abuser would likely benefit from punishment versus 23% for the substance use disorder. Now let's look at social threat. When it came to the question likely to be socially threatening, the abuser was 58% more likely to be threatening than 42% of the substance use disorder. Now look at this one, the contribution blame. When we look at the blame, right, blaming an individual for their illness, they were blamed. The abuser had 76% was considered blamed for their difficulties of substance use versus only 24% for a substance use disorder. Now, when we get into contributing, their problem was the result of an innate dysfunction over which they had no control over. The abuser was looking at 21%, so pretty low that they didn't have control over it. When we look at the substance use disorder, that was 79% were viewed as having a problem that they had no control over. So basically the opposite of blame. Now, self-regulation, more able to control their substance use without help, without seeking help. 67% people felt as though the abuser could control their substance use. And only 33% of people with substance use disorders were able to control their substance use without getting help. Really, this is pretty heavy information. This is mind-boggling because, again, remember, there is no other information that was given. Literally, it was compared by the terms abuser versus use disorder. Other than that, they both had a substance use concern. Technically, they both either had a substance use issue. They both had issues with substance use. Let's talk a little bit more about this. Why is it in our culture that we view substance use as a huge stigma? Yes, we can talk about culture. There's so much cultures that make up America and then the United States. And there is subcultures in how they view stigmas. Though there's huge information that is lacking in support and resources for support of substance use disorders. Our healthcare system does not view substance use disorders as the same as a mental health disorder, and they use the medical model. The brain is the organ that is affected, and when it comes to the medical model, the organ of the brain is the one that's utilized for treatment. And that is where people are treating the brain. We're looking at neurotransmitters. We're going to get into another video when it comes to the neurobiology, though it's a neurobiological component, but it's not viewed the same. That is the concern that many professionals, such as myself, who treat co-occurring disorders and educate counselors and therapists on co-occurring disorders have. A lot of individuals who gain their master's in counseling have literally the same information given to them as I've taught on this topic. And these are literally slides that I've used in my educational classes. Though they're very lacking in their ability of understanding and conceptualizing and treating substance use disorders alongside mental health disorders. It is very important that we promote co-occurring disorder treatment as the same as mental health treatment and abolish the stigma of substance use disorders. The symptoms that go along with having a substance use disorder has a lot to do with the stigma. Many people don't understand the symptoms. Every mental health disorder has symptoms according to the DSM-5. Substance use disorders as well have symptoms that are very related to each other. There can be denial, rationalization, minimization, justification. Those go along with substance use disorders. The denial is not always a choice. And we get into that more when I go over the stages of change. Denial is an illness. When we look at the mental health aspects of denial, it's because an individual is not able to process the struggle that they experienced. And when it comes to substance use disorder, a lot of people see denial as a choice and see it just like the abuser in this case. I find it very sad. And I hope, and my mission and my hope is to educate people, whether you're a teacher, whether you're getting your master's degree in counseling, whether you're working with mental health as your primary focus. Gaining a better understanding of substance use disorders will overall help the people that you see and you want to support through their mental health. When we don't address the substance use, in addition to addressing the mental health disorders, then we're not providing clients the best services possible. It's a significant difference from seeing someone just for one or the other of substance use first before mental health versus alongside each other. Very different outcomes. It takes a lot longer when they don't have that co-occurring component. And they might slip through the cracks when they're bounced around from one treatment center to another to an outpatient center for mental health. There's just becomes a lot to juggle. That's why I'm very passionate about co-occurring disorders and being able to help support people and fight the stigma and advocate for people to have the same care. I hope that today we covered information that really helped you to have a better understanding of substance use disorders and how it correlates and is a mental health disorder. My hope is to provide you more information as we go on to be able to support not only yourself as an educator and a counselor and just a family member of someone who has a substance use disorder and a mental health disorder, but just to, in general, have a better understanding. My hope is to support you so we can support the people who need our support. Thank you for listening, and I hope to provide you more videos. Have a good day.